Recording again. So good morning, good afternoon, I think good morning, good afternoon for most of you. Thank you so much for joining. We are going to start soon, but I just wanted to maybe start with we are expecting quite numbers of people. This Zoom is open for more than up to 1,000 people. So I think it should be fine to accommodate everyone. We have a lot of our housekeeping things. So before we start, I just want to touch I want to explain the housekeeping. So we will use Mentimeter a lot. So please open Mentimeter. Can someone maybe put the link to the Mentimeter? Direct link to the chat box. So you can go to either www.menti.com and then put the code 1800369 or put the direct link to the Mentimeter. And you can also scan the QR code here. That will take you to the right page. Please keep the Mentimeter page in the different browser or in your Skype or your iPad or any pad. So because we are going to use it regularly throughout the event. And also please use the Q&A box instead of chat when you ask questions. So that makes it very easy to facilitate the discussion. So please use the Q&A. And if you want, we will have our question and answers regularly. So if you want to speak rather than chatting, please raise hand and then we will unmute you so that you can speak. And again, feel free to speak in your language, in Spanish or French. We have a simultaneous interpretations in Spanish and French, thanks to IOM. And then when you send anything in chat, please use panelists and attendees, then it will go to everyone. I think the default is panelists, but please use panelists and attendees. And as I mentioned, we have our interpretation. So please, if you want to use French or Spanish, please click this French or Spanish, and don't forget to mute original sounds so that you can hear you don't hear the both sounds at the same time. I think just for the time's sake, let's start. So my name is Masumi Yamashina. I'm one of the organizers. This is a GBV risk mitigation into protection work. Thank you so much for everyone for joining. This is organized jointly by CCCM Cluster, GBV Guidelines Reference Group, especially CARE, IOM, UNHCR, and UNICEF, and GBV AOR. Again, same. So we have quite packed agenda. Will be our Jennifer Chase, Global GBV AOR Coordinator, will open the sessions, and we'll have our speech also from the BPRM. Then we'll do a little bit of the ice break exercise and have our overview of the session presentations. And we'll have a very interesting thematic presentations from the field on our GBV integration in HLP, GBV referrals, GBV risk mitigation into compliance and feedback mechanism, and GBV risk mitigation in data collection and monitoring. After each thematic presentation, we will have a Q&A. And after the thematic presentation, we'll have a participatory exercise, again, by using Mentimeter to really have your opinions and feedbacks and recommendation to GBV risk mitigation into protection work. And then finally, we'll have a closing remarks from the Global Protection Cluster coordinators. So without taking more time, I will hand over to Jennifer Chase, Global GBV AOR Coordinator, for her to open this session. Over to you, Jen.
Hi, everyone. First of all, it's very exciting to be doing this webinar today with all of you. And I just want to say that the GBV guidelines, if you're familiar with them, were revised in 2015. And since then, many sectors have accelerated their efforts to mitigate GBV risks in their work across multiple sectors. And we had a stock taking in 2019 in Bangkok, where we included CCCM, camp management, shelter, and the WASH clusters together with the GBV subclusters. And we really saw a lot of achievements Of course, with turnover and the many different challenges that are faced in the field, it is hard to put something systematically in place, but we've really gained momentum since the revision happened in 2015. Today, our focus really is on the protection cluster, since this is the GPC forum, and we're going to have different speakers sharing examples of risk mitigation work that they're doing within the protection cluster, as well as with CCCM. So we're going to focus, as Masumi mentioned already, on 3 thematic areas. One is GBV integration into housing, land, and property. So we'll hear about women's challenges in HLP and also how HLP actors have addressed these challenges in Nigeria, Somalia, and Somalia. And the second section will be about GBV referrals, GBV risk mitigation into complaints and feedback mechanisms. And we have a field example from Cox's Bazar, as well as experiences of GBV referrals, and then data collection and monitoring, both looking at DTM and looking at the MSNA from a global perspective, as well as examples from South Sudan. So we have a really very exciting agenda for all of you. The event itself has been organized in collaboration with the CCCM cluster, with the GBV guidelines reference group, with CARE, IOM, UNHCR, UNICEF, and the GBV area of responsibility. And we want to give a special thanks to CCCM for the critical role that they've played in GBV risk mitigation, with IDPs especially. I want to thank all of the presenters who've taken their time in their busy schedules to put together their presentations and share and exchange ideas with all of you. But really, for this to be successful, we also want to hear from you. We want to hear about your own experiences in the field, and we want to hear about your challenges and get ideas from you on how we can move this forward and become more effective and more systematic about risk mitigation work in the future. We're very interested in all of your opinions, and we really have planned an interactive session. I know it's challenging to be on so many different Zoom presentations, so we've tried to make this as interactive and personal as possible. And we also really want to thank the generous support of BPRM and the other donors who have supported the GBV risk mitigation work over the years. So looking forward to an exciting session, and we will have this recorded, so it will be available afterwards. And just to remind everyone, it is available in multiple languages simultaneously, so you can listen to French or Spanish. That's it from my side, and looking forward to hearing all of your experiences as we go ahead. Back to you, Masumi.
Thank you. Thank you very much, Jennifer. And now we are very happy to have our Catherine Bacharak. Sorry for my pronunciations. She's a Gender Equality and GBV Officer from Bureau of Population, Refugees and Migration, one of our leading donor on GBV risk mitigation, who is leading the Safe from the Start. So we are very happy to have her and then hear donors' perspective on why GBV risk mitigation is very important. Now over to you, Katie. Thank you so much.
Thank you, Masumi. Thank you for inviting me, and good afternoon and good morning to everyone. We at PRM, we're pleased that the importance of gender-based violence risk mitigation is being highlighted at this year's Global Protection Forum. And we would like to really thank our partners, many of whom are likely participating in today's event, for their hard work on this issue. The United States is committed to preventing and responding to GBV, particularly the protection and empowerment of women and girls, as a life-saving priority and integral part of every humanitarian response. The United States Women, Peace and Security Strategy, released by the White House in 2019, reiterates our commitment to support solutions to prevent and respond to violence against women and girls, and ensure women and girls have safe and equal access to humanitarian assistance. Though much has been done to further our goal to protect and uphold the rights of displaced and conflict-affected women and girls, and we as a global community of practice are headed in the right direction, we aren't there yet. Despite the incredible progress by everyone attending this session today, prioritizing the needs of women and girls is still not yet a part of the DNA of emergency responses. many practitioners continue to need to justify prioritizing the unique needs of women and girls in emergencies. And while there's consensus that GBV happens at all stages of a humanitarian crisis, and we know it is amplified in emergencies, programs to address this critical issue are rarely prioritized at the onset of any crisis. Unfortunately, we are seeing this trend continue in the response to the COVID-19 pandemic. This is why the United States remains committed to our Safe from the Start initiative and our involvement with the call to action on protection from gender-based violence. Through Safe from the Start, PRM has channeled more than $112 million to systematically prevent and respond to GBV at the onset of emergencies, and a significant amount more to fund core and specialized GBV responses through other mechanisms. We have invested in a number of activities that advance GBV risk mitigation, including enhancing the participation of local women-led organizations, training and capacity building to assist first responders, supporting the regional emergency GBV advisor mechanism, and supporting our IO and NGO partners to build safety mechanisms into their core humanitarian systems and structures. It is imperative that our partners include risk mitigation measures in their work. As such, all applications for US government humanitarian funding, regardless of sector, must include a gender analysis within their proposals, demonstrating that gender dynamics have been assessed, analyzed, and integrated into the program, including plans to mitigate any gender differences in access, participation, or decision-making. Specific GBV risk mitigation strategies should be included in the gender analysis. All US government humanitarian partners are required to provide a protection from sexual exploitation and abuse code of conduct that is in line with the IASC 6 core principles relating to sexual exploitation and abuse. USAID's Bureau for Humanitarian Assistance requires a corresponding action plan to operationalize their codes of conduct, which is also encouraged by PRM. We have learned that preventing GBV in particular requires long-term and meaningful investment in increasing gender equality and addressing harmful norms, attitudes, and behaviors. We continue to urge our colleagues, both internally and externally, to proactively involve women and girls in decision-making and program design, consult and collaborate with communities in identifying and mitigating risks, and prioritizing funding to service provision and safety mechanisms. These are among the biggest gaps in the humanitarian field and areas that can make an exponential difference if prioritized in emergencies. The COVID-19 pandemic is unfolding on top of what was already the greatest displacement crisis in global history and demands a response focused on protecting and empowering women and girls. We have an obligation to lead this effort, get this right this time, and ensure that addressing GBV is not a second-tier priority. Thank you.
Thank you very much, Katie, for this very encouraging speech and also reminding us the needs of, again, including like GBV risk analysis, gender analysis into all this like a proposal across the sectors. It's really encouraging to hear. Thank you so much. So we will, with this note, we will start some activities in Mentimeters. Sorry. So this is the site. If you are not managed to open it, please use again our menti.com and the code 1800369. And also use the direct link to go to our Mentimeter. I will share. Sorry, I have a bit of a technical challenge, but now it's back. Did everyone manage to go to Mentimeter? Yes, we see 2 people, 10 people. There's a direct link to the Mentimeter at the chat, so you can click it if it's easier. Okay, now I see. Okay, many people joining. So let's go to our first question. What is your role? I have quite a lot of people in global role, GBV practitioners. Great. Okay, we have a lot of global roles people and the GBV practitioners. We have also GBV subcluster coordinators. We have also our good numbers of protection practitioners. That's great. And two CCM protection, CCCM practitioners. That's great. Others, I'm very curious. If you are willing to please share what's your roles in your chat box. Excellent. So let's move to the next questions. Thank you so much. So which country are you based in? You can type in, again, you can type in French or Spanish or any other languages that you feel comfortable with. Okay, Senegal, Mozambique, Turkey. It's great, quite a variety of people. Excellent. We have Iraq, we have Turkey, we have lots of people from Switzerland, Senegal, Turkey, US, Venezuela, Dominican Republic. Wow, yes, that's great. Panama, Honduras. Very good. Thank you. So we have quite a diverse group of people today. That's excellent. Thank you. So I'll ask the last questions before I hand over to Erin. So what is your expectation to this event? And thank you. I see also some people write your countries responded into chat box. Excellent. We have a lot of people from different countries. So top expectations, I want to learn about examples and strategies related to integrate GBV risk mitigation into protection work. Great. I hope we can address that. And also how to do how to integrate GBV risk mitigation. Great. And third is the CCCM. I want to know how to integrate the GBV risk mitigation to CCCM. We have less people, or not so many people who wants to share example, but we would have opportunity to share your examples. So please also feel free to share your example in your chat box, but we will also have our time to share your examples. Excellent. Thank you very much. So we will stop for now, the Mentimeter, and then we will come back to Mentimeter a bit later. So now over to Erin. Erin Patrick is the global coordinator of GBV Guidelines Reference Group. So she's going to give just overall presentation of what our session is about. Over to you, Erin.
Thanks, Masumi. So Jen Chase from the AOR gave a great overview of the individual presentations. So we can skip that slide in the interest of time when we come to the end of my quick presentation here. No, not that one. Masumi, you can go back one. It's the last slide. We'll just skip, but it's fine for now. So I'm just going to give a quick overview of what risk mitigation is. So thanks to those of you who took the pre-survey that was available upon registration. It was really interesting getting the information from that pre-survey. One of the themes that came out was that there was some lack of clarity or demand from participants to learn a bit more about what GBV risk mitigation is and what it's not. So I'm just going to take 1 minute to do a very quick overview so that we're all on the same page when we talk about GBV risk mitigation. When we talk about programming or coordination to address GBV in humanitarian contexts, we typically divide it into 3 areas. We talk about GBV prevention, which is preventing GBV from occurring in the first place. We talk about GBV response, which is managing the consequences, working with survivors to address the consequences of GBV after an incident of GBV has occurred. And the third bucket, which is what we're focusing on today, is risk mitigation. And what that is looking to identify the contributing factors that increase the likelihood that an incident of GBV might occur, and taking action to reduce those contributing factors. There's lots of different types of contributing factors. So when we talk about GBV risk mitigation overall in humanitarian action, what we mean is humanitarian service delivery, and that's all aspects of service delivery, so programming, coordination, operations, etc., that doesn't cause or increase the likelihood that GBV occurs, meaning that we look at our programming or our work and make sure that we're doing everything we can to make that work as safe as possible. It's service delivery that proactively facilitates and monitors vulnerable groups' access to services. So this is looking at who in the context in which we work are the most vulnerable, and how can we make sure that the services that we're providing or the services that they need access to are as accessible to them as possible in as safe a manner as possible. And then the third aspect of risk mitigation and humanitarian action is being responsive to GBV risks in the environment. So being perceptive about maybe it's not something that we directly control as a humanitarian actor, but where are we locating our services? How are people getting to and from services? What is the context, the overall context in the environment? Military groups, ethnic rivalries, that sort of thing. Can we pay attention to that and adjust our services to make sure, again, that they're as safe as possible for everybody that we're serving? So that's what we're talking about broadly when we use the term GBV risk mitigation. We want to identify GBV related risks that are in the environment and take action to reduce those risks. This is everybody's responsibility. This is not just limited, GBV risk mitigation is not just limited to the protection cluster, although, or protection actors, although obviously protection has a key role to play. It's one of the reasons that we've brought our colleagues from CCCM in today to share examples of how GBV risk mitigation is also integrated into other sectors' work. But we did want to focus specifically on protection today because it's one of the areas that we haven't spent as much time focusing on over the last few years since the release of the revised GBV guidelines that Jen mentioned earlier in her presentation. There's a belief sometimes that the protection cluster is responsible for GBV, and with the GBV AOR and GBV subclusters sitting under the protection cluster. This came out in the pre-registration survey as well. It's often thought, we'll just hand everything over to the GBV actors. It's their responsibility. They can take care of it. And so what we want to do today is really show examples of how protection actors themselves can take action to mitigate the risk of GBV in protection programming and data collection and monitoring and all of the various activities that surround programming. But also bringing in additional examples from other clusters of how we can coordinate across sectors to ensure that our programs are as safe as possible. One more slide and then we can move on. So I just wanted to bring your attention to, as Jen mentioned, the GBV guidelines. What's shown here on the screen is what we call the thematic area guide for protection. You can find this on gbvguidelines.org. The link's up there in the PowerPoint. This is the part of the GBV guidelines that's specifically dedicated to protection. We have a similar one, similar thematic area guide also for the different AORs, so child protection, HLP, also mine action, and CCCM. There's also, WASH, nutrition, food security, and so on, but just thinking about our work here today. I also want to mention briefly the GBV Pocket Guide. I think this will come up in the course of one of the discussions. It is a resource for non-GBV specialized practitioners to give advice and examples on how to safely respond to a disclosure of GBV that occurs in an area where GBV specialists may not be available. We have it in hard copy and also in app form, and I'd love to take this opportunity to announce that we've just released it in several new languages, both the hard copy, which you can download from our website, as well as the mobile app, which you can find on either the Google Play or the iOS store by searching GBV Pocket Guide. And then I also want to bring your attention to the GBV risk mitigation and COVID tip sheet that we put together at the beginning of the COVID crisis. It provides some examples and recommendations of how different sectors can adapt programming to address some of the new or changed risks related to COVID and GBV. And there's obviously a protection section in that tip sheet as well. So I'm going to stop there. You can skip my next slide, Masumi, because Jen already covered it, and hand it back to Masumi to start our thematic presentations. Thank you.
Thank you, Erin, for this great overview. So we will have this, we will start the three thematics presentation now. We start from the GBV integration into housing, land, and property. And it's really exciting to have two presenters to present on how GBV risk mitigations in housing, land, and property. I think it's a very rare opportunity to hear about their work and example. So really, I'm happy to now introduce you Peter Buala. He's a lawyer who works with NRC since 2017 in Northeast Nigeria as HLP coordinator. So now over to you, Peter.
Hello, colleagues. Good afternoon, and also maybe good morning to wherever you are from around the world. I'll be taking this presentation on GBV integration into HLP. I hope you can hear me loud and clear.
Very, very good, very well.
Okay, so I will proceed to have the slide. Yeah, briefly, just to talk about the project and what we do. The housing, land, and property subsector was established sometimes in 2016. And the basic essence is to coordinate and respond to housing, land, and property needs in the northeast of Nigeria. And so in brief, we'll talk about our intervention. We have coordination meetings and we organize events. And also in these meetings and events, we try to look at legal barriers hindering people, especially people who are displaced from enjoying and accessing their housing, land, and property rights. And also we provide due diligence guidelines and support to partners who want to provide intervention in respect to housing, land, and property. Once it has to do with the use of land. And so in this area, you find HLP providing assistance to WASH partners, providing partners support to FSL, food security partners, and also providing support to shelter and CCM. And so this project also is a platform where we enable HLP actors to coordinate their activity. Here it's bringing in the stakeholders, especially from the part of the government, and also the community leaders, the traditional institution, and other stakeholders who provide services or have mandate in respect to housing, land, and property. And so that has been able to enable us to build a strong referral pathway in order to respond to HLP issues as they come in, and also with the support of the protection sector, jointly advocate for needs as they arise. Next slide. Now, looking at how women access to HLP, we understand the ability for a woman to access HLP is a crucial factor for her to be able to escape an abusive relationship. Women stay in a relationship because of the fact that they cannot find shelter. And so we've been able to see these in our counseling session, where most of this have been reported in our counseling session. And so women don't want to leave because they don't have shelter. And it's always difficult for them to have access to that. So it takes me to the next slide where I will explain this further. In our intervention, we've come across these issues that have been faced by women, especially women who are displaced. We've seen female-headed households having difficulties in accessing rental accommodation. Here, landlords don't want to give houses to women, to women who are female-headed households. The simple question is the fact that why? Everyone wants to know why, and the reason is because women always have the inability to pay rent. They don't have a source of livelihood because they are displaced, and so the landlords are not willing to give them housing. And in that instance, in some of this instance, a woman is requested to come with a man, and the man stands as a guarantee to that particular woman to guarantee the fact that she can pay rent. Now, in instances where a woman cannot do that, we've received cases where the landlords have asked a particular tenant that if you can't pay rent, then it means I have to grant you favor. And in that extent, then it means the man will now start making, the landlord makes advances towards that particular female-headed household. This is one of the challenges we've experienced in implementing project within the Northeast. Also the fact that a lot of those women who were displaced came into the city centers. They went into tenancy relationship that were undocumented. For the fact that most of them are illiterate and they don't have the requisite knowledge to demand for tenancy agreement. And because of the pressure to access housing, you have limited housing. They rent, we're just in a rush to do that. And the challenge here is when you ask them, when did you go into this house, into this rental accommodation, when is the rent supposed to expire? They don't have that particular information. So at any point, the landlord feels comfortable, he feels, okay, at this point, I'm okay with you guys, then I'm going to tell you to move. And usually these evictions are mostly done orally. You don't have written documentation to either prove otherwise. They are mostly done by verbal notice to those particular tenants. So it's quite challenging getting those information. We had sessions with land officers and also directors of planning and also land housing officers who are members of the HLP subsector. And they have raised concerns that most of the rental houses don't provide adequate segregation. And here what I mean is the fact that you have the wash facility in one place and the demarcation is between the male and the female. What they have advocated for is the fact that you segregate it by location, not by putting a male in writing on the door of the wash facility, but provide that the left hand is for use of the male, and the female is the right hand side is used for female for the female household. So by that instance, if a woman is seen, if a man is seen in a location where it is exclusively left for the female to use, then it becomes an issue. So they have actually advocated that yes, a lot of these GBV cases are happening because the men and the women access the same location. So can we advocate to town planners, to people who build houses, to actually shift that into providing it as to left for male, right for female, then it will be able to reduce and mitigate cases of GBV. Now we've seen instances where there's a problem where women find it very difficult to claim assets of their deceased husbands because of customary customs barrier, and sometimes it's because of the fact that they find it difficult to also assert that right. A lot of women have been intimidated. If you want to claim this right, then it means you're going to leave this house. So a lot of them find that difficulties to also do that. Next is the problem of who do you go and report this? Where do you go and report this kind of concern? Because this is being perpetrated mostly by the relatives of the husbands. And this is quite challenging. We've seen this in the field reoccurring. And now we've seen the fact that some of our humanitarian response have increased cases of GBV, and looking at provisions of shelter and food, and also livelihoods, which has the support have been given to women. This have raised concerns because in some instances, women who are now receiving food from humanitarians have insisted that they have their rights against their husbands. And to go to the slide as to what we have done to be able to address this, we provide legal counseling session. And at this session, it allows women to discuss and talk about what is their problem. And that is where we identify these issues and pick them up, and we take them for response. We have links with the Federation of Women Lawyers, the Nigerian Bar Association, the Ministry of Land, and try to see how we can respond to this. And also trying to build the capacity of the women on how to protect their HLP rights. Next slide. We also provide legal assistance, and in our legal assistance, we do that through eviction monitoring and coordination, where our staff, our field monitors go around the field, especially informal settings, go around and check which location have been served with notice and what is happening. We've been able to respond to some of these issues, especially when it comes to eviction. Eviction has been on the increase, and we've seen the fact that a lot of them are coming as a result of the fact that returns are also increasing eviction. So we receive evictions and we receive referrals also from the Ministry of Women Affairs in respect to support for cash for rent in order to prevent immediate eviction and also mitigate the risks of eviction. So we provide that cash for rent intervention to mitigate this, and sometimes we provide it for a period of 6 months or sometimes for a period of 1 year. And we've been able to support shelter rehabilitation. Here, what we do is for the shelter partners, we do the due diligence check and provide the MOU, the Memorandum of Understanding between the house owner and the IDPs who are supposed to stay in those particular areas. In other areas, we've been able to negotiate stay, where we've asked and negotiated access and asked landlords to please halt evictions for a particular time until alternatives are being sought for those IDPs. And we've also set up a platform where women who have paid for rent are able to collect evidence of payment for tenancy. Next slide. Next slide. Yes, in 2019, the HLP in NRC was able to provide and come up with an assessment which informs advocacy. It was entitled Displaced Women Housing, Land and Property Right in Northeast Nigeria. It was aimed at raising awareness and advocating for law reforms. This research brought out a lot of things affecting women. And the result of what we've been able to do as a result of our intervention is the fact that we provide training materials and we adapt it to the context. And so we've been able to increase the knowledge of women in respect to housing land, and also the use of collaborative dispute resolution services, especially where we target those particular group as the women who are in need. And so more women are now able to access existing dispute resolution structure, and they now show confidence in accessing those structure and also the outcome of the decision passed by those structures. And we've also improved referral of HLP issues and concern. We've been receiving a lot of referrals from different partners, different organizations, including the government partners. Lessons learned and challenges is the fact that we receive referrals in respect to challenges of this women when it's already late, when sometimes you have 2-3 days when it is left for the eviction to actually happen. And so this has always been a challenge for us, despite the fact that we do a lot of monitoring. Sometimes you get information too late, because sometimes the IDPs try their best to look for the alternative, and when they don't, they now inform you. A lot of cultural practices are norm. Women are afraid to claim their HLP assets as it relates to this increases their risks of violence, especially women whose husbands have been associated with the armed opposition group. Those women and some of those women who have been able to be those women who came out from captivity. That's part of what we've also experienced and is a challenge to us. And also accessing justice. We have absence of ADR system in the most of the return areas. And so it's quite difficult for women to access those justice system, especially when it comes to the formal justice system. A lot of cases in respect to housing, land, and property go through the formal justice system. And so we advocate more for the use of the alternative dispute resolution. Security restriction has also limited access to how to reach area. And so a lot of some of these areas where they are hard to reach, we don't have information as to the HLP status, HLP data in respect to housing, land, and property and what affects women in those areas. Part of the lessons learned for us is the fact that it is quite important working with the government. We have actually achieved more working with the government in the sense that we now even have referrals from the government. This is one of the points which is even very, very important for us. And so once we receive those referrals from the government, then we try to see how we respond, and the government now know what we do, and the government also in some areas provide support. I think this is what we have been able to do. And for us, we are trying to look at where the Global Protection Cluster, AOR, will actually support in-country coordinators with analytical report on protection concerns. Sometimes we want to know the trends that is happening in other countries. We want that this platform to be where we'll be able to get global trends. For us, we feel it is also important to advocate for free access to justice, especially for the formal justice system for displaced persons. Access to justice is quite a concern for us, so we feel it is also important to access it and advocate for more access for women, and also trying to encourage partners to understand how HLP is integrated into humanitarian and developmental intervention. A lot will be achieved if all partners who wash, shelter will also understand how HLP is being mainstream and while doing the due diligence in providing intervention. Over to you. Thank you all.
Thank you so much, Peter. It's very rich presentations. I think we all heard about these problems, the women's special programs in HLP. So it's really great to hear these solutions that your work. So we will now hand over to Nora, the example for Somalia. But for anyone, if you have a question, please write in Q&A. We will open the floor after Nora's presentation. So Nora is Nora Atino Ochiang's, again, apologies for my pronunciation, is a protection officer with UNHCR Somalia and has over 13 years of humanitarian work experiences. And now she's based in Mogadishu, Somalia, and then working as a protection officer. So now over to you, Nora, for your example. Thank you very much.
Thank you very much, Masumi. Good morning, colleagues. Good afternoon, colleagues, from wherever you're listening from. As Masumi has introduced me, my name is Nora Ochieng. I'm working with UNHCR, but just to add that I am a member of HLP working group in Mogadishu. And therefore my presentation will be looking at the GBV risks in the context of HLP and what UNHCR and HLP have done in order to mitigate this risk. And so before I begin, I just want to give a brief background of Somalia, the challenges that the women, especially the IDP women and girls are facing, the security that impact the women and girls, and the challenges that women have in accessing formal and informal justice, issues of documentation, the issue of land. And therefore, to begin with, let me just start by providing you with the overall statistics of our persons of concern in Somalia. Somalia has a total of about 2.6 million IDPs residing in over 2,300 IDP sites. And this is according to the CCCM latest statistics. Now, out of this number, 2.6 million, almost 400,000 women and almost 1.7 million are children. And therefore you can understand the vulnerable groups within the IDP population. As a UNHCR, now that I'm talking on behalf of UNHCR, I also want to just share with you some of our persons of concern and the numbers. Refugees are about 35,000, majorities are from Yemen. And then we also have returnees, about 95,000, majority came from Dadaab following the tripartite agreement that was signed in 2014, and of course the host community. Now, the security situation in Somalia is volatile and tense. And most of the security incidences occur around the IDP, the rural areas, where IDPs reside. And again, this is the information that is available to us by the UN Department of Safety and Security. And incidents, most of these security incidences are perpetrated by Al-Shabaab. We are looking at kidnapping, forced abduction. We are looking at mortar attacks, assassinations. And therefore, this has greatly, put women and girls at great risk of risk, including gender-based violence. The issue of land tenure system in Somalia is complex and unclear. The issue of inheritance, women do not inherit land. And also this also puts them in a very, very vulnerable position. Land is held by the strong clan members. The ability for women to even acquire land, traditionally because of the traditions and customs, land is mainly held by the male, female members. But because of also multiple evictions, you find that even if women had the male support, because of multiple evictions, they are left even vulnerable, exposing them to further risk of GBV. According to Humanitarian Country Team Somalia Centrality of Protection Strategy of 2020, priority number 2, the protection strategy of Somalia 2020 prioritizes 3 areas, and priority number 2 talks about IDP risks, an issue that women face. So this is an issue that is acknowledged even within the HLP working group where we sit, or where UNHCR sits. An issue of forced eviction have been discussed. It occurs in Mogadishu, Baidoa most, and even when the COVID-19 began, and maybe to just provide an update with regard to the status of the moratorium in the context of Somalia, UNHCR has been at the lead in advocating, and I can report in this meeting that it has been successful. When it was first issued in April, during one of the HLP meetings in June, July, the eviction trend had actually dropped from 16,000 to 2,000. And this was attributed to the positive advocacy, which not only involved UNHCR, but also with other actors and the government taking lead. In fact, in one of the locations, such as Baidoa, where it was positively received by the government went on air and actually pleaded with the landowners to prohibit eviction during the COVID. And so we are seeing efforts from the government and the support from the government in certain federal member states and championing for this advocacy. Now, going into some of the key risks and issues, I'm going to only mention 3, but there are a number. But the ones that are mainly impact on women are the forced eviction. As I mentioned, forced eviction in itself, we believe is a contributing factor, and I'm going to explain why. You find that when women are forcefully evicted, and I want to give you a picture of an informal IDP site where forceful eviction occurs, and it can occur for several reasons, either lack of documentation, non-payment of rent, or because the landlord wants to develop the land. So what happens in this scenario? The livelihood is disrupted. Now, once the women's livelihoods are disrupted, what happens? They're exposed to poverty. They end up making very radical decisions or negative coping mechanisms, which may result in marrying off young girls in order to supplement family income. Also, when forced eviction occurs, the education of young girls of school-going age are disrupted. And what happens in that situation? Girls, school dropout, early pregnancy, marriage. Those looking at the shelter also being disrupted. The context of informal sector, where for occurs, what UNHCR and other actors does, for instance, where shelter we provide the now sometimes the women this again also exposes women to GBV risks. The other area which I also wanted to highlight in this meeting is access to justice. Now, the formal and informal justice system. Now, justice system is the most required. The cultural relevance, accessibility, and also the fact that maybe it's affordable. But for the women who are not represented in these forums, who sometimes feel that when their case is not before this it's not, so in fact, the disadvantage when you don't access, justice, then the chance of being exposed is high. The formal issue must be fact. Somalia is just coming out of years of war. The institutions are weak. Now is when we are starting to strengthen, the capacity of some of these institutions, whether legal or ministries related to land. So sometimes because the formal justice, and some of these IDs are living in areas that are controlled by far from, specialization, and for them moving to areas to access the justice, to even hire the services of a lawyer. Remember, in most cases, even the livelihood or the income, they don't even have enough to eat, and therefore places them at a greater risk of GBV. We will lack documentation in terms of HLP. I also mentioned one of the main reasons.
No, sorry, you're breaking. Yeah.
Okay. Can you
No.
hear me?
Yes, yes.
Yeah, sorry about that.
Yeah,
So
no, it's-
when you talk
maybe we can move
okay.
to the next.
Women lack of valid documentation also is a cause. Now, some of the actions we have taken, and I'll try to be very fast in the interest of time, the moratorium that I mentioned at the beginning has been very successful. That has actually mitigated the risks of eviction. And our active participation working with the actors in the government, eviction rates have gone down. And also the lessons that have learned specialized services. One of the opportunities in Somalia as mentioned in this forum is that we have over 50 GBV. This is a huge opportunity, and therefore tapping into their expertise, tapping into the resources is very key. Working with authorities, government, religious leaders also is key. In one of our present, our the government, especially in Mogadishu, have been seen as a menace. They neither report to the government or the IDPs, and therefore working with them, because they've been in the settlement and seem to be high has also yielded positive fruits. And of course, as my colleague of previous presenter mentioned, health awareness raising on HLP. Let them know one of the advantage that we have, the country is coming out, and so their national policy, they are drafting policies that are very much aligned with international legal instruments. We have the national eviction policies, for instance, which speaks to some of the rights of in the legislation, and also the for carrying out eviction. Remember, forced eviction in itself is not illegal, but if it's done within the confines of the law. So people to understand that you need time, 90 days to be formed, so that the government, negotiate the government to get land, in a distance and move. So it's important for them to understand the laws that speak to their rights. And in doing this, we work all. Actually, and capacity building is one of the key activities under house party. Members are so that there are national elections, HLP in the context of forced evictions.
Nora, it's a very bad connection. I'm so sorry. Maybe it's better. Maybe you could summarize some of the key, maybe action results and lessons learned.
Okay. So maybe some of the lessons learned, I would just say that the whole of society approach, working with all the sectors, including the government and the community, and also the humanitarian country team, centrality of protection, which emphasizes women and girls are vulnerable. One of the lessons that I wanted to bring to the table is the fact that the importance to inform the community, especially during when providing assistance. Let the affected population, women and girls know what are entitled to, so that they do not experience sexual exploitation and abuse by either the humanitarian actors. So them knowing the quantity of the assistance they're receiving and that aid is free is very key. That I'll come to the end of the presentation of the bad network, this presentation and now welcome questions. Back to you, Musumi.
Thank you so much, Nora. And I'm so sorry the connection was not really great, but we will share this presentation with everyone. And then please do ask a question to Nora. But thank you so much, Nora. And again, interesting that our similar problems comes in Nigeria and then Somalia. And also like similar actions are taken. So I see a lot of questions already are asked. Maybe we can start actually already. I see Peter answering some of the question, but for the benefit of everyone, let's ask the question. So the question from Maria is in some countries, there is a tradition of wife inheritance. Is there any good practice which can be shared on how this was managed? Peter, over to you.
Thank you for that question. For us, we have a challenge in respect to that, where we have two laws, plurality of laws. We have the Sharia law, hand in hand with also the English, received English law. Now, this is a concern here in the sense that for that inheritance under Sharia, we don't have a problem with that. But for those who are not subjected to Sharia, that is where we have a problem. And so in the Northeast, you have only one state that have domesticated laws that allows women to inherit. So other areas, especially from Borno State and those persons who are in the southern part of the state, don't have a particular law that they can fall into for that. And so what we use here, the best option for us here is to have the traditional institution. And so what we did was we had on board the highest traditional institution who sends a member of the traditional institution of its cabinet to attend our monthly HLP meetings. And so those issues, as they come, we pick those issues and refer it to them, and they refer it to that particular traditional institution from that particular location. And so a response are being provided in respect to women who are denied assistance. And in this, we work with partners, especially working with the International Federation of Women Lawyers. And so we use them as part of our platform to move ahead in responding to this. But what we advocate for is to have laws that are domesticated, that will be used even if partners decide to want to go through the formal justice system to claim their rights. Thank you.
Thank you very much, Peter. Again, just to please write your question to Q&A. We might not be able to answer every question for now, but we'll try to follow up even after the webinar. And also, if you want to speak up, please raise your hand so that we can allow you to mute. And please write French or Spanish. We have a translator, so no worries. So next questions, again to Peter. I know you already answered. So how you ensure active participation and contribution by the persons of concern, especially towards the behavior change on matters HLP negative norms that contribute to gender-based violence?
Yes, on that, what we try to do is on active participation. We try to involve them in every process of what we do. We provide training. And what has been more effective for us is one-on-one counseling. Mostly after our information session, we have a breakout session where we ask women who have counseling needs. And so they come one-on-one. For those who are comfortable talking to women, we have the women assistants with us and officers with us. So they go to the women to talk about their problems. And so once those have been identified, immediately we forward same to partners who we know provide psychosocial support. We have partners who do that, and so we provide referral to them as part. That's not what we do in respect to psychosocial support. So we have that referral platform, and also looking at how do we do that in respect to GBV sector and mitigating risks. We and the GBV sector work together in the protection sector meetings. And so we work closely with Sylvia in respect to seeing how we mitigate GBV in Northeast Nigeria through housing, land and property. And sometimes we have also requested support from GBV to look at how we could also integrate it in our own programming, which we did recently. Thank you.
Okay, thank you again. So also you answered a question from Christina Pius as well. So the next questions, I think we have a lot. Just one is for it's more for you, Nora. You mentioned the weak institutions as well as the cultural context, but based on that, it's the government of Somalia or other countries willing to be involved and make some changes. So maybe it's for both of you, or maybe Nora first, if you want to answer how the Somalia government is doing to address that, and Peter, if you want to complement. And then I will pass to Leah to answer questions. And then I think we have to move to next session, but we will come back to more the questions that we couldn't answer these sessions. Over to you, Nora.
Thank you very much. Yeah, thank you very much, Masumi. With regard to the weak institution, I just want to refer to Sustainable Development Goal 16, which talks about strengthening of institutions. This is a collective responsibility where all the humanitarian actors in their own way work with the relevant ministries to strengthen, whether it's software or hardware. I'll give an example. What UNHCR is doing is to domesticate the Kampala Convention. I'm sure we all know that's why the Kampala Convention in 2019. It's very much aligned with strategy. So to do an activity. So for me, when it comes to institution, it should be a collective responsibility geared towards goal 16, where we work to strengthen the judiciary, so that these documents, they can go to a court and be confident that their case will be heard, because the institution that have been created, speaks to them. They are represented, both men and women. So for me, that's how I would respond to that question. But I'll leave it to Peter, maybe to take it on.
Yes, just to add to what Raz actually said, for us, we understand the fact that we really have weak institutions, and part of the problem is the fact that there is no law. She talked about the Kampala Convention. Nigeria is a country that has not domesticated the Kampala Convention. And so the Kampala Convention cannot be used within Nigeria until it is domesticated. We have it signed, but it has not been domesticated for the past 11 years. That is our particular challenge. So now, in order to support this, the government came out with an IDP policy, and a national IDP policy, which the national IDP policy is just a replica of the Kampala Convention. But that does not at any point gives the IDPs any right to demand for anything. What we actually do now is the fact that we are actually supporting those institutions. We have actually provided mediation training to members of some of these institutions, especially the Ministry of Land and the Judiciary. We provide them with mediation skills, so that we know that some of these women lack access, especially knowing where the courts are, and also providing and also having the ability to pay for those services. So in order to do that, we try to provide support through capacity building, and also supporting those institutions through the provision of materials and support. And as we know, the weak institution also goes to the fact that currently we are seeing the government trying to review the laws as it relates to cases, especially when it comes to GBV as a part of the improvement in the laws. And fortunately, I'm part of the committee trying to provide support in that aspect. So we hope when those laws comes out, it will also protect women against GBV. Thank you. Over.
Great. Thank you so much, both Nora and Peter. So final question from Leah. And then can I also request Peter and Nora maybe to type answer some of the questions coming from in the Q&A box so that we can answer. Thank you. Leah, over to you.
Thank you so much, Manushi, and thank you, Peter and Nora, for the good presentations. I think the question that I had in mind, Peter just responded to part of it. It was actually on how we could ensure that we have, ownership from governments, given that these are displaced populations, and giving such support. As we continue to give such support, it was how can we ensure that they own this, and then there is durability and continuity even without humanitarian or development actors offering such kind of support. Thank you.
So Peter, maybe do you have anything to add? I think you already answered most of the.
Sorry, wait.
Nora, yes. Hi.
Hello?
Yes.
Yes, I just got to respond to one of those questions that I'm looking at the chat.
Sorry,
that talks about in relation to women and girls with disability.
Okay.
Yes, this is something that recently I have seen in the field. A lot of things have been done, and we don't provide those. We hardly see those aspects of people who are disabled. Until recently, my colleague drew me to the fact that a woman who was psychologically sick was pushed out of a particular camp and was given a particular site far away from other IDPs, people who were displaced, to stay. Until when we looked at that situation, we now understood the fact that in other camps, there were these things happening where people who had disability are secluded from persons within the community. So what we did was to go around, map out some of this IDP sites, and go around and ask if there were persons with disability, women and girls with disability, and specifically try to see those persons and see their housing needs and where they live. And that was how we were able to detect some of those cases and respond to that. I hope I've answered your question, Shireen. Thank you. Over.
Okay, thank you. I think we need to move on to the next. I think Leah, Peter already answered your question before, but Peter, did you hear the question from Leah about the government, the kind of sustainability? If you want to add anything, maybe or you can write in the chat box and then the Q&A. We might have more time later, so I will come back to our rest of the questions after this representation. Now we are moving to our next topics on GBV referrals and GBV risk mitigation to complaints and a feedback mechanism. We will have a Lama Elu-Batal. She's the IOM site manager and the site development program manager in Cox's Bazar, Bangladesh. Lama will be presenting on GBV risk mitigation in CCCM activities with a particular focus on the management of GBV referrals through their compliance and feedback mechanism. Lama has been in Cox's Bazar for close to 3 years, so very familiar with the context, and she's recently completed her missions and then they are moving to another context. So welcome, Lama. Now over to you.
Hello, everyone. So starting with CCM and GBV and why are we having this specific discussion? As mentioned at the beginning of the webinar, we all agree that GBV risk mitigation is the responsibility of all sectors. And we understand very well that all staff, whether protection or non-protection, should know how to support a survivor and should know how to ethically and safely respond to disclosure of GBV cases and GBV in general, which is crucial to GBV risk mitigation. Considering that CCM actors and in Cox's Bazar or in other camp settlement or camp-like setting, CCM does work and interact with a lot of people in the camp, all ages, all genders, and has quite a big outreach through the programs and the interventions that CCM does, such as the information dissemination, service monitoring, communication with communities, and the community leadership mechanisms. And therefore, this coordination, close coordination between protection, sector actors, and CCM is key priority to ensure that we have a strong linkage between our sectors. Specifically, when it comes to the complaints and feedback mechanism, this is the core CCM activity in most contexts where CCM is active. And in IOM, in Cox's Bazar in Bangladesh, the IOM CFM was also tailored to, of course, receive all requests, information, or complaints regarding any services in the camp, as well as protection concerns, and therefore there were lots of challenges as well as lessons learned, and we're going to talk about it. Referring such sensitive cases requires that we have very strict protocols that are also known to the CCM staff to avoid further harm and to also prevent retaliation for reporting GBV cases or seeking services, as well as stigmatization in a community where also anyway women have restrictions due to cultural barriers, as well as norms that restrict women in general from accessing services or freedom of movement, etc. And therefore, the CCM plays a very important role. So we have to adapt the CFM standard operating procedures to specifically support GBV risk mitigation efforts and strengthen data protection for protection cases in general, and that definitely for GBV cases. Yes, so taking a step back and looking at the overall context of Bangladesh, as of August, around 860,697 Rohingya refugees are now residing in the camps in Cox's Bazar. They are settled around 34 camps, and out of the total, 52% are women and girls. Each camp, the size of the camps varies. However, each camp has a CCM actor or agency, and a government counterpart, who the camp in charge. And therefore, CCM and the government work closely together in terms of camp management for each camp out of the 34. The number of actors in the camp varies between 15 and 34, and therefore the numbers can be quite big in terms of service providers. And therefore this resulted in creating a focal point system to coordinate sectoral interventions amongst the sectors themselves and between the sector actors and CCM / the camps in charge. In IOM camps, where also we do direct implementation, each camp has an intersectoral camp complaints and feedback mechanism, which is directly managed by the CCM team. Next slide, please, Masumi. Protection mainstreaming is a core responsibility and a very important role that CCM plays, and therefore, beyond GBV and just generally speaking, the CCM in Cox's Bazar, we do work with an AGD approach, where in every camp, we do mobilize groups that represent age, gender, and diversity, and therefore in each camp, we work very closely with groups of women, adolescents, females, males, with imams, with older persons, etc., and men, of course, and this is across all camps. To increase participation and to ensure that the communities are participating with this from an AGD perspective, each group is, we engage with each group in designing and leading their own community projects. So each group has the chance to design their own interventions, to propose their own interventions, and then we just support them to implement them. Around key areas, of course, such as sports, leisure, access to services, site development, amongst others. And we, and specifically when it comes to people with disability, we rolled out a people with disability checklist for CCM, where on a bi-monthly basis, a team that also focuses on protection mainstreaming goes to the camp and checks the progress that our CCM teams are doing across the camps in terms of inclusion of people with disabilities, across all activities that CCM does, as well as in the camp life, access to services, access in terms of the physical barriers, inclusion of people with disabilities in the projects that I just mentioned, within the AGD groups. Sorry, Masoom, yes. Another initiative was specifically focusing on child protection safety risks, where we look into risks from a child protection perspective. And this is specifically during COVID-19, where we realized that children who have no access anymore to protection, safe center, child-friendly spaces, or to education facilities have been really suffering the most. And we have had many children also losing their lives, unfortunately. So that's another initiative that was as well rolled out and that is being done across all the camps. When it comes to women specific interventions and inclusion, we can proudly say that the Women Participation Project, which started as a pilot project across several contexts, where Cox's Bazar is one of them, was very successful, and women committees were established, trained, and women committees also included women with disability and have received trainings on women leadership, and they became very active, very empowered, and they do play a key role in camp management in the camps where the project was rolled out. And at the moment, we are also rolling out across several camps. Focusing on CCM and GBV risk mitigation, one initiative that the CCM teams across the camps is doing in the context of Cox's Bazar is specifically rolling out, so IOM globally is rolling out the GBV in IC, GBV in Crisis Action Plan. And in Cox's Bazar, the CCM teams is doing an action plan for each camp to ensure to roll out specific GBV action plans with commitments for each team, aiming at addressing gender and GBV at the camp level. And therefore, each CCM has commitments when it comes to gender and GBV in CCM for each camp. Inclusion of women across the program remains a high priority, and this is across the CCM interventions such as the cash for work with increased cash for work, women participation in cash for work, women committees, women-specific projects, which the women are designing themselves and implementing for their communities. On the other side, CCM plays a key role as well in the camps when it comes to SEA, prevention of sexual exploitation and abuse. And in each camp, there's focal points from the CCM teams who are trained on reporting mechanism and safe referrals. And therefore, also that mechanism has been established. This is an example of the women participation project, where women also have now have a leadership role. They are also trained on PSS and therefore are providing support to their own communities in terms of access to information, in terms of also providing feedback. They are also playing a role in terms of the link between the community and the complaints and feedback mechanism. And in cases where women are not able to access for reasons related to culture, to gender, to GBV, the women are also key in that process. So the women committees are now established across all IOM AOR camps within the 18 camps. And the Women Participation Project also in 3 camps and now being rolled out into the other camps as well. So going to specifically the complaints and feedback mechanism, how does the system operate and what happens when it comes to complaints or feedback or requests related to services in general versus when it comes to protection specifically. Generally speaking, the CFM system is, we have desks, static desks that are known to the community. But we don't only rely on the static desk, and therefore, in parallel, there are also mobile CFM data collection, where the teams go into the community and talk in every block to the groups in the block, and also door to door to ensure that vulnerable groups, people who have less access, and specifically women, are also reached. In general, whenever someone has any question or any concern and are approaching the CFM, the teams are trained on how to collect the data using the COBO, which is then collected through that mechanism, and it goes into a central database. So we don't use paper-based mechanism. It's all through a system, and everyone and people, once they upload the information, the system is only accessible by very few people. Emergency referrals, so in general, all the referrals that come through the CFM desk are referred on a weekly basis to the service providers. Of course, every time someone comes to the CFM, we record all their information, but the consent is always taken in terms of sharing the information with a third party. Now, when it comes to emergency referrals, these cases are shared immediately and not necessarily waiting for the 1 week referral system, but rather immediately through the via WhatsApp, the coordination groups, or by phone. Protection referrals specifically are considered emergency referrals, and therefore they do not follow the mechanism 100%. And the teams are trained on how to receive protection referrals that are anonymous, that remain anonymous, and where the data is not recorded in details beyond the unique code and the general type to understand that this is a protection referral, just for the sake of analysis and data management. However, the details of the cases is not recorded for data protection purposes. Referrals are done immediately to the protection focal point following the referral pathways, and we consider the case closed the moment the case is referred from the CCM team to the protection actors and the protection focal points. Depending on the case, if it's CP, it goes to the child protection focal point, GBV to the GBV focal point, and SEA specific cases are referred immediately to the SEA focal point following the SEA referral mechanism. And they are not recorded in the CFM, so they follow a separate mechanism that is established in Cox's Bazar for reporting SEA. In all cases, informed consent is obtained for the referrals when it comes to protection cases, and all the cases, as I mentioned, are considered closed as soon as they are referred. So since January,
Sorry, can we maybe, or because of the time, maybe
yes.
I can skip two and then come to you. Yeah.
Okay, so so for example, this is an example, because it's very difficult sometimes to differentiate between a woman that is coming to complain about something that is related to access to services, which is very general, and sometimes specifically women approaching the CFM desk complaining because there are protection concerns hindering their access to the services. So for example, if a woman comes to the CFM desk and says that I cannot access food because my food card is lost, or for example, my registration information is not updated and therefore the family composition is not reflected in my card. This is a CM case, which is directly followed up by CM with the food actor or the food partner. However, a woman can approach a CFM complaining that she's not able to receive the food, but when asking why, and this is why, it's very important that the teams that are manning the CFM desk are asking about the reason. And in some cases, it turns out that a woman, the husband or has left her and took the card, and therefore she lost access, her and sometimes her and her children, which means that automatically this flags concerns in terms of GBV. And in this case, the case is referred to the GBV focal point from the CSCM, from the CFM desk directly. And therefore, the CFM plays a major role as a source of identification. And what we always tell the team is that when in doubt, it's always better to consult with protection. And therefore, this relationship and back and forth between CCM and protection is extremely, extremely important. Data considerations, very quickly. We do not use the type of risk analysis per se. However, we use the data in general in terms of to analyze trends around safety and that require timely mitigation measures to reduce the likelihood of GBV incidents occurring. And sometimes these can be examples related to lighting in the camps, lighting of specific wash facilities, access to firewood, access to latrines, as well as women having like long distances to cross to access women to a water point or any other key wash facilities, amongst others. If protection trends, including risk of GBV, are identified through the CFM data, it is always discussed with protection and GBV through the coordination mechanisms, and this is vice versa, from CCM to protection and GBV, and as well as protection GBV to CCM, which then, of course, is very important for joint advocacy, as well to ensure and put concrete mitigation efforts, which proved to be very successful so far and in the past. So why we're focusing on capacity building, just to say that it is extremely important to train CCM staff and volunteers of the GBV referral pathways, as well as how to safely and ethically support survivors in the event of disclosure. It's very important to ensure that all CCM staff and volunteers have updated copies of the referral pathways when involved in CFM as well as beyond. It's very important to ensure that CCM staff always have protection and GBV sessions and refreshers. Sometimes we realize that there's confusion between CCM and protection, and therefore these trainings for both teams are extremely important because there are thin lines between CCM and protection when it comes to referrals, to cases, to safety, and concerns in a camp or a camp-like setting. We can move to the next slide, and this is the last slide. So, generally speaking, COVID, of course, has caused severe challenges for CM teams, and specifically for CFM, because limited access of humanitarians to the camps meant that we had less people able to respond, and therefore the referrals and the time frame between the referral and closure of the case took a bit longer. Therefore, training volunteers and having remote management proved to be also very successful as one of the examples of the best practices when it comes to access. Restrictions on protection activities had a negative effect as well on children, women, and persons with specific needs. There were less services, there were disruption of women and children activities, safe spaces specifically were closed, the learning centers, there were less livelihood opportunities, which meant that negative coping mechanisms were increasing and violence as well. And therefore, as I mentioned, community-based volunteers played a key role to bridge that gap. Data sharing remains a very big concern. As I mentioned, we work with authorities, and therefore, we have noticed that in the past, authorities were also requesting more and more to share protection data, and specifically GBV cases. And those requests were being made to CCM by the authorities. Therefore, the strong advocacy and coordination between CCM and protection sectors, where we had to, of course, align positions, was key and remains key in terms of advocacy and mitigating those risks when it comes to the humanitarians and working with government counterparts. Trainings on GBV and SEA for non-protection staff, including beneficiaries and volunteers, remains a very, does help a lot and is key as well in terms of risk mitigation, as well as a source for identification and referrals when it comes to protection cases in general and GBV cases in particular. Over. Yeah.
Thank you very much, Lama, for very comprehensive presentation of your experiences. So now open for the questions. I see already one question from Jenny about C, and also I think this is a right place to ask about question from Robin. So Robin's question was that it's not working, why? But it seems like in your case it's working. So maybe the question is kind of it's the opposite. Why do you think, why did you integrating GBV into CCCM work? What worked? That's the first question. And second question is from Jenny about sexual exploitation and abuse. If it is dealt separately from GBV cases, what steps towards survivor-centered care do you take for these cases? So these are two questions to you first now, Lama.
Okay, so just in general, protection mainstreaming, as I mentioned, is a core function. It's a core role of CCM, and therefore we do mainstream protection across CCM, across wherever CCM operates in the world. Why does it work? It doesn't always work, but we continue trying and we continue to ensure, and this is what I mentioned as well as one of the practice, to put action plans and to ensure that CCM is always one of the things that works is ensuring that the CCM teams are also aware and trained on GBV as well as protection in general, and understanding that this is also a core responsibility. This is their role. This is not, and therefore not creating this division between CCM versus this is only protection and this is only a GBV role. And that understanding of the role of CCM and that integration within the work makes it that makes it part of the job that they do every day, and making sure that it's also integrated within the program in terms of making checklists for our CCM teams, where every month or 2 months there's a checklist to monitor the progress of the CCM teams in terms of protection mainstreaming and how they are improving the empowerment and of women, the inclusion of women, and there are targets. So it is embedded. It is part of the targets. It's embedded in the design of the CCM interventions, and it's a core function. And those trainings helped a lot create that mentality, create that spirit, and ensuring that our staff understand that this is also their role, as much as it is their role is not to respond to specific cases and get involved in the case management, but in terms of mitigation, prevention, as well as working closely with protection, that is a core this is an understanding and a core responsibility. Just to come into the SEA, this is more the way the Cox's Bazar also, the Cox's Bazar response is built. This is in the interagency coordination mechanism. GBV is a sector, of course, under the protection working group, but there is also a dedicated PSEA coordinator for the entire response, and there is a specific PSEA network, and there is a PSEA commitment for every actor, where every organization has a focal point, and therefore there is a training done. I can give the example of IOM, where all the staff, 100%, were trained on PSEA to understand their responsibilities in terms of reporting and the referral mechanism, and to ensure that it goes through the mechanism rather than to prevent that more information, that the information is spread, to prevent also that the information about the survivor is leaked, and to ensure that it's done in a safe and ethical manner. So it is the way the response is also built. And there was a training specifically, of course, for all the humanitarian actors. However, considering the presence of CCM on the ground and the outreach capacity, the focal points across the camps from within CCM were specifically appointed as the PSEA focals to ensure that referral mechanism directly to the PSEA network following that specific referral mechanism. I hope I answered both questions.
Thank you very much, Lama. There are several questions, but just for time's sake, we will now pass. But I think maybe, Nora, if you can type some of the answers to you in a question and a box, that would be super helpful.
Yes.
And also, just also adding to Robin's or what Lama said, it's really what Lama said is correct about the that's now, this is CCCM's responsibility. When I think other sectors think this is their responsibility, then it's easier. It's actually, we see more success in GBV, for example, with GBV risk mitigation integration, because it's not GBV's responsibility. For example, as Lama said, it's CCCM's responsibility. And I also just wanted to make sure that for the GBVs that our responsibility, especially for non-GBV actors, is be ready for referral. When someone seeks support, it's not us to kind of actively identifying cases or anything. It's just we need to be ready when survivors seek support. And then as Lama provided, that there is a referral system, so the survivors are referred to the services that she needs. Okay. So we go to just the next, because now we've been hearing a lot of interesting story. We wanted to check if you're still with us. So again, can you please go to our Mentimeter? We will do a bit of the energizing exercise before we move to our next presentations. But again, let me just take this opportunity to say thank you so much, Peter, Nora, and Lama, for sharing super interesting examples and answering the questions. Thank you so much. So let's move now to our Mentimeter. Please, I'm going to show my screen. Okay, so simply, are you still with us? I don't see anyone. Oh, yes, 3 people. Okay, great. Yes, some people losing focus. That's very natural. That's normal. Okay, no one is not the situation of the bear. Okay, good. Excellent. So more people are still voting, but I'll go to our next one. So it's great that most of people are still interested in. A few people are losing focusing. I completely understand. Let's do a bit of quiz. Excellent. So we'll just do a quiz, and then our winner. So it's a competitions as well. Let's start the first questions. Oh, sorry, I passed one questions. So question is, GBV risks is the same as GBV incidents. If you think GBV risks is GBV incidents, so sexual violence is GBV risks, please answer yes. If you think no, GBV risks and GBV incidents are different, please pick no. Time's up. Yes, great. Yes, it's not. GBV risks and GBV incidents are different. For example, GBV risks is, let's use the example of a toilet because it's easy. That a long distance to the toilet, or there is no locks of the toilet. Because of that, the risks of the likelihood of GBV can increase. So these are the risks that we are talking about. Next question. GBV risk mitigation is a critical component of the centrality of protection. Yes, 100%. I'm glad. Yes, it is the critical component of centrality of protections. Then last question. Oh, sorry, this is GBV risk mitigation. It's same as GBV prevention. GBV risk mitigation is GBV prevention. It's same. If you think yes, it's same. Yes. No, it's not same. Then please click no. Yes, so there are some differences. So it's different, but again, GBV risk mitigation considered as part of preventions, but GBV prevention is really focusing on the root causes of gender-based violence, like gender inequalities and lack of respect to human rights and so on. While risk mitigation is really addressing risks, which can contribute to prevention, but really focusing on addressing risk, as I mentioned, for example, making sure there's locks on toilets or making sure that distance is not too far away and so on. So who is the winner? We have Puffy as a winner. Congratulations, Puffy. Sorry, we don't have any chocolate to give in online, but thank you so much. Then congratulations. Now, hopefully, we are all a bit more energized and then ready to hear next presentation. Next one is again next one could be also very interesting. It's about GBV risk mitigation in data collection and monitoring. And Lama also mentioned about our challenges in data collections and so on. And it's just also important that even though we protection actors, if we are not prepared, we might cause more harms when we do the data collection. So let's hear now. I'm pleased to invite Frey. She's now working as the monitoring and evaluations and knowledge management specialist in UNICEF. But before she joined UNICEF, she worked in GBV AOR as GBV information management. So now over to you, Frey.
Hi, everyone. Great to be with you today. So I was asked to talk a little bit about data collection for GBV risk mitigation. Obviously, in the interest of time, this will be short, but please do ask your questions via Q&A if anything is too fast or unclear, or if you want to ask anything else. So just a quick overview. I'm going to talk a little bit about the information needs for GBV risk mitigation, very briefly about forms of data collection or how we can get that data, and kind of general things that we want to keep in mind when we speak about data collection for GBV risk mitigation. And I hope that in this brief presentation, we will have a bit of a shared understanding of what we need. So before I start, I think it's good to remind us as to why we collect data. So what we see oftentimes in the field is that a lot of people collect a lot of data by surveying a lot of the affected population, but then not using it. But obviously we want to collect data particularly for two purposes, strategic and operational decision making. And of course, in the end, our aim is to improve the program quality and safety for women and girls. So we want to just keep that in mind from the outset so that we actually collect data with a purpose. So what do we actually need to collect? So here you see a very colorful kind of visual. This is what we call an analysis framework. And that is basically a framework that spells out kind of to know what you need to know or your information needs. And in this framework, we divided this in 3 general kind of categories: the society level, community level, and individual level. So at a society level, what we're talking about really is the overall systems. For example, the legal system. What are the laws in place for women? You already heard in the HLP presentations a lot of things about legal codes, etc., because they can really spell out the rules for women and girls, as well as more overall, what's the economy, etc. like. Then at the community level is where we get more into kind of risk mitigation in particular, especially when we look at the response environment, so the environment that we operate in, as well as social, cultural, and religious practices at a community level. We'll zoom into that a little bit later. And then we also have information needs more at the individual level, so really kind of the types and cases, and incidents of GBV. However, I want to already state this from the outset, and we're going to talk about this multiple times, that this is not something that we are collecting. This is only information we get through case management. So just to say that, yes, of course, this is an information need, but this is not something that we collect. What I do want to highlight in this framework is the specific needs groups. So for all sectors, as well as for GBV risk mitigation, of course, we need sex, age, disability, and diversity disaggregated data. What we kind of want to make sure, what we know, no matter whether we work in food or wash or whatever, is who are the specific needs groups. For example, adolescent girls or female-headed households. And we use that understanding of groups with specific needs to really have that lens to see how our programming should be. For example, if we have female-headed households, let's say a lot of them in one campsite, and we know that there's restrictions on freedom of movement, it would be fairly easy to conclude as a food actor that maybe they have difficulty accessing a distribution site. So use that lens of who are my specific needs groups to do your data collection as well. So we're zooming in a little bit on the community level. So the response environment basic needs. So there we have what we call the availability, accessibility, acceptability, and quality. Lots of big words, but we call this an AAQ framework. And then we look at all the different sectors through this framework. I'll explain that in a little bit more detail. What we also have is the kind of social, cultural, religious environment, or more like the community environments. For example, what we would like to know is like, what are gender roles? For example, what's the division of labor in the household? Knowing these kind of things also helps us really well with GBV risk mitigation. For example, women and girls are often responsible for fetching water or for collecting firewood. So that is already something that we can take into account when we then look at the energy sector on the left within the response environment, because we already know, like, okay, this is where risk can occur. Vice versa, we can look at things from gender roles, like who makes the decisions in the household, or who makes the final say on the finances. Because then we can, for example, see that, you know, if a family doesn't have a lot of money and a woman has a health problem, like, will she be prioritized to deal with that? So I would say generally more, the ones on the right would be more kind of data that would be traditionally more provided by us, as in protection or GBV actors. And then on the left is really kind of this sector's type of GBV risk mitigation that we can also work with our sectoral colleagues to obtain this information. So let's dive a little bit into this AAQ and see what we mean by that. So basically, AAQ is just a framework. You can go to the next slide, Masumi. That kind of spells out what eventually is the humanitarian outcome. So AAQ are just terms that provide different reasons as to why a good or a service is not available. We also provided a link underneath. Perhaps we can also put it in a chat box. But it's kind of a framework that spells out why is a good or service not available. So for example, for accessibility, if I look at education, the school could be too far. it could be too costly, it's too dangerous to go there. And if you then use your lens of the specific needs group, so why would an adolescent girl not be going to school, or why is it not accessible to her? Or maybe it's the acceptability, why it's not acceptable, for example. So if you use this type of kind of looking at it per sector, then you can come up with a lot of the GBV risk mitigation indicators or things that you need to know. So let's look at an example for this. This is an AAQ for WASH. So for example, for WASH, if I want to look at my availability in terms of GBV risk mitigation, we may want to look at how long does it take to go to your water source, for example, to fetch water, because if women and girls are the ones fetching water, we want to know how long is it there, and then how long does that take to get it. If it takes very long, we know that the risk may increase. Is it accessible? So why, for example, can you not go to a sanitation facility? So for example, maybe it's maybe it's too far away, or maybe it's not safe to go there. Then we look at, oh, here we have a lot of reasons actually. So obviously there could be a lot of reasons as to why you would not be able to access a facility. And what we don't want to really kind of register is what exactly is the reason in this case, for example, in this particular camp, and also what are the consequences. For example, we know in Cox's Bazar in Bangladesh that a lot of women and girls do not feel safe using a sanitation facility. And what are the consequences? They're eating less, they're drinking less because they just don't want to go there. So there's a lot of consequences that we can then spell out, and that's why we have to kind of improve this programming. Then the next up is the acceptability. So what are the preferences and cultural habits, for example? So to consider when people are using either toilets or sanitation facilities, etc. So how can we program to make sure that women and girls actually want to use it or are allowed to use it? The quality. So we could look at, for example, on a latrine, are the functional locks, are the functional lights? Because if they're not, then maybe they're unsafe and we could see more GBV incidents. I also put use here, which is kind of pasted onto the AAQ. But again, depending per sector, you can look at all these different indicators or different types of information and see how can we actually improve GBV risk mitigation across a program like this. So I said it before, but the last part of the framework that we didn't really talk about so much, I'm just spelling it out here in some sort of animation, but of course the types of GBV and GBV consequences. So we're just going to talk a little bit more about how do we obtain this data, such as this AAQ. But no matter what we do and how we obtain this data, what we're not going to do is include any direct questions that would ask about whether somebody has suffered an incidence of GBV, what type, where, how. So we're just not asking these questions, no matter what assessment we do. So how do we obtain this data? So generally, of course, we would advise in any case, prior to any assessment, to do a secondary data review. You can also integrate it into an existing assessment, or the third one was that you could conduct your own assessment. So you can integrate it into an existing assessment, which is more at a strategic level, or you could, for example, for a more operational level, do your own assessment, such as maybe a safety audit with multiple actors, so also with food security, with WASH colleagues, etc., to set that up to get more an operational profile of what the GBV risks are. So I'm briefly mentioning the integrating into large-scale assessments because there has been quite some work done there. So for example, with DTM, which is the displacement tracking matrix from IOM, is a large-scale key informant assessment that takes place in a lot of countries. So in the link there, you already find a lot of questions for GBV that you could incorporate into DTM that are safe to ask that pertain to GBV risk mitigation. So for example, again, we're not asking direct questions on GBV, but we're asking, for example, for WASH, like how many toilets or latrines are well lit, or how many are separated for males and females, or how many paths going to the toilets and latrines are well lit. So this will give us an indication of where possible risks are, and where we could do maybe a more operational level safety audit to kind of follow up at that, more granular level to get the information of what do we need to do here. The second assessment that I'm mentioning here is the MSNA, the Multisectoral Needs Assessment, that is also done in a lot of countries by REACH. So this is a household level kind of data collection. So here, for example, depending on the sector, there's already a lot of integration done of questions where you could see, for example, barriers or risks to accessing services or goods, depending on the sector. So we have an example here for education. So why are your girls not attending school? And then the household can give any of these kind of options as to why a girl is not attending school. So this also gives you a more kind of strategic overview of what could be the particular problems that you can then follow up on in more detail operationally. So lastly, some things that we want to keep in mind when we talk about data collection. So this is definitely a lot more about assessments that I've been talking about. Of course, we want to obtain data at every stage of the program cycle. So something like a safety audit is kind of more like monitoring, right? So that would also cover kind of that aspect. So there's definitely different ways to incorporate obtaining GBV risk mitigation data at every stage. So some of the main assessments that I just mentioned, which is, for example, key informant or a household, does not necessarily always ensure women and girls participation, because a key informant can be male. We're also going to hear later on a presentation where there's definitely been a lot of steps taken to reduce that, so to incorporate more women and girls' voices. But the same with a household survey, it's often asked to a head of household, so it tends to also be a male. So there's definitely other ways as well that we can work together to ensure women and girls participation. For example, more operationally, when we're doing safety audits, maybe we can include women and girls as well. Again, we do not include any direct questions on GBV, no matter what type of data collection we do. And we just have to remain cognizant of the risk that can be involved. So I didn't mention all the reasons as to why we don't do that, but there's a lot of ethical and safety concerns. For example, if I would ask a woman in front of the head of household if she's ever suffered GBV, we don't know, maybe the perpetrator is sitting right next to her. So it's super unsafe to do those kind of things. So we have to just be aware of like what risk can be involved and be mindful of what we're asking to whom. So lastly, the last thing I wanted to mention is, you can go to the next slide, sorry. What we also see quite often is that, a lot of data is being collected, but then maybe we're not doing as much as we can with that data. So we're asking a lot of questions, but some of these questions or the data from those questions we're not really using. So we just want to highlight that there's definitely several things that you could do, whether it's at a strategic level or an operational level, to relay this information to your colleagues. So at a strategic level, for example, you can consider making like a more, let's say, analytical brief, where you combine anything that you would find from your secondary data with your primary data, so the data that you just collected. So for example, here you can see a little bit of an overview here you can see that something like this has been done. Or if you're a protection cluster coordinator or a GBV coordinator, for example, you can use this type of data at the strategic level for documentation for your H&O narrative, for example. An operational level kind of data, what you could do, for example, with safety audits, if you do this in several different camps, you can make a site profile. So listing, where are the GBV risks higher? Is it in this side? Is it in that side? And then you can target where you're going to start. Or you could make a dashboard, for example, your progress board on GBV risk mitigation, etc. To conclude, so you just want to spell out your different information needs. So know what you need to know and start with that. Then for each sector, if you do GBV risk mitigation, use the lens of specific needs groups. So use the specific needs group that you have in your context to kind of see why or why not they would be able to access different goods and services. Focus on an AAQ, so the availability, accessibility, acceptability and quality framework, or a similar type of framework. And then you can integrate this into existing assessments or conduct your own. And then we want to just be cognizant of the risks and not include direct questions on GBV incidents. And maybe as well, the last thing that I should mention is that even if we're not talking directly about GBV incidents, that we also have to make sure that the staff and personnel is trained on this, so that enumerators are trained on what to do in case a GBV incident does get disclosed. So make sure that we have the referral pathways in place, etc. So definitely there's a lot of things to keep in mind, but there's definitely data that we can obtain on GBV risk mitigation.
Thank you, Ray, for the great presentations. I think it's really our setup very good to our, I think tones for these next presentations. So next, I'm also happy to introduce Andrea. I'm not going to even try because I won't do it. So Andrea is the he's the project officer in South Sudan, South Sudan in IOM, who is working in DTM. So Frey already mentioned how DTM could be used for our GBV, identifying GBV risks. So Andrea is going to give us our example, how South Sudan using DTM to identify some of the risks. Over to you, Andrea.
Thank you very much. If we can move perhaps to the next slide. This is just the introduction. So I wanted to start actually by recalling some of the key recommendations and guidelines, and I won't go into detail here because Frey already talked in detail about this, but from a data collector's perspective, we really need to have this clear in our mind when we are planning a data collection exercise. Because as a data collection expert, we're not necessarily protection experts. And at some point, we have to accept that our knowledge of the sector is limited, and that we have to really defer to guidelines that have been put in place to make sure that the safety of the respondents is paramount. And in particular, the WHO guidelines, they're telling us we need to weigh the benefit of collecting data. It always has to be greater than the risk of collecting this data. We have to avoid using personal interviews unless it's a last resort. And we have to have available referral systems in place locally before we can start collecting data. In terms of the IAS guidelines, we also have a clear recommendation that tells us we should assume that GBV is happening. We should not try in an emergency to establish the prevalence of GBV. This is not needed to start acting. We can collect data on other factors around GBV. We do not have to wait to establish the true prevalence if this is, if this is a goal. We can move to the next slide. In terms of what we do as DTM in South Sudan, we mostly focus on community level data. We rely on a key informant network. So if you go back, I think we've skipped one. Yeah, we rely on a key informant network to gather granular community level, so location level data on both IDPs and returnees throughout all of South Sudan. As of round date of mobility tracking, this is our main data collection exercise, which took place in March 2020. We monitored over 2,700 locations, and here we're talking about IDP camps, villages, and neighborhoods in urban areas across all of the 78 counties in South Sudan, hosting 1.6 million IDPs and 1.5 million returnees, both from South Sudan, IDP returnees, and from abroad. When we think about improving the quality of the data that we're collecting on women and girls as DTM, we've taken a number of measures over the past couple of years. In South Sudan specifically, we've really tried to ensure that in each location, at least one key informant is a woman, is a female person. And this is because men often lack the knowledge of a GBV risk, and they tend to underreport this information. It's true, however, that, and I will highlight the challenge, even if we are choosing female key informants, there can still be bias. We do not have to believe that everything that we're told is absolutely correct and absolutely unbiased. There can still be bias if the key informants are pursuing local agendas. And this can be true of both women and men as key informants. There are local political agendas and power dynamics at play that may create an incentive for them to underplay the GBV risk in a certain area. And this is something that we always have to be aware of when we are collecting and analyzing and especially interpreting the data on GBV risk. We also made an attempt to increase the number of female enumerators. And this is because, as we know, it's much easier for women to talk about the risks that they're facing with other women. The female key informants will feel more comfortable if they are speaking with female enumerators. And I want to tie this with a brief sentence in the IOM GBV in crisis framework, which reminds us that addressing GBV is contingent upon addressing gender inequality. And this was mentioned by Bakrak from USAID earlier. It is a key point, and we face this in our operations because there is, in rural areas, a scarcity of skilled female candidates. So to the extent that there is this gender inequality, we have limitations in our ability to hire female enumerators, and this also affects the quality of the data that we are collecting. This is something that as well we have to be aware of when we are doing this data collection and when we are interpreting the data that we collect. And finally, we've made some efforts to mainstream protection, GBV and PSEA training for our enumerators, despite some challenges, large network of enumerator, and the fact that there is quite a big turnover in our field volunteers. If we move to the next slide, more practically, in South Sudan, we are collecting two types of indicators on GBV risk. The first is about the presence of areas avoided by women and girls. It's a proxy for community perceptions of security. And the second one is about GBV risk mitigation in WASH. And here we have three indicators under this broader category. This information is relevant for all humanitarian actors. It's not just relevant for GBV specialists. For instance, the mapping of GBV risk hotspots telling us whether there are areas that are avoided by women and girls because of fear of GBV is essential before food and NFI distributions, which are predominantly attended by women and girls in South Sudan. The location level indicators that we collect are weighted in our analysis by the population of each settlement, and we do this to try and obtain some county and state level summary statistics. Of course, the location level information is important when we get down to the nitty-gritty of actual operations and field partners, but if we want to understand what the situation is at the country level, we need to obtain some summary statistics, and it's important that we take into account the population of each location. So even if this is not household data, we can still provide summary statistics. We're not restricted to just doing this type of location level analysis, but we can also understand what the patterns are across the country. The caveat is that we do not have information on the differences between women in a specific location. I think we skipped 2 slides. Yes, so if we go next, this one. In practice, moving to the data that we have collected. This is data collected in March of 2020, and close to 1/3 of IDPs and returnees in South Sudan live in settlements where the KIs are reporting the presence of areas avoided by women and girls. This gives us a measure of the importance of this problem. And we can see that the problem varies between states. There are 10 states in South Sudan. On the left in blue, you can see the proportion of IDPs living in settlements reporting areas avoided by women and girls. And on the right in green, you can see the proportion of returnees. So you can see that there are particular issues for IDPs in Upper Nile, Jonglei, Central Equatoria. These are areas where there is, or there has been until very recently, still active conflict in most of these areas. There's still, in some of these areas, there still is active conflict at the moment. And same to some extent for the returnees. We can move to the next slide. It's also interesting to break down this information by the type of settlements where women and girls are living, and between urban and rural areas. And what we see is that the proportion of IDPs living in settlements where there are these areas avoided by women and girls, where we have some proxy information that there are negative perceptions of security for women and girls, is higher in host community settings. And it would actually be very interesting to do some additional research around this to understand why this is the case. One possibility is that in camp settings, the community tends to be more homogeneous. It tends to be people who have come from the same area and that perhaps have been able within the camp to reconstruct their regular family and community structures. While in host communities, IDPs may be more dispersed and surrounded by people with whom they have more limited familiarity. But again, this is just a suggestion and a possible interpretation, and we don't actually, we haven't done yet some in-depth qualitative research to understand this factor. In terms of the difference between urban and rural, what's quite interesting is that for returnees, there is quite a difference between the two. Returnees in rural areas tend to report areas avoided by women and girls much more commonly than in urban areas. But the same does not apply to IDPs. And this may be linked to the specific vulnerable status of IDPs that adds to the security risks that they're facing, including the women and girls in their community. If we move to the next slide. This is just for illustration. I will skip over it, but it's just to say that there is quite a lot of variation even within each state in the degree of risk that we are capturing through this indicator. You know, it's really a country with a lot of diversity, and there are specific hotspots of risk that need to be targeted by programming. We move to the next slide. We now move to the data that we're collecting around GBV risk mitigation for WASH services. And the main picture here is that GBV risk mitigation measures are extremely rare in South Sudan, even very basic risk mitigation measures. So for gender-separated latrines, you can see more than half of the IDPs in most states are living in settlements without any gender-separated latrines. And Unity, where we see that the IDPs are doing relatively better, that's because of the presence of Bantu POC site, which is a very large UN-managed camp. And of course, in such a location, there is much more attention from the humanitarian community. We can move to the next slide. Same for another simple measure, the presence of locks that can be locked from the inside within latrines. There is very little that has been done in this respect. And what you can see is that there is also quite a bit of unknowns. There's quite a bit of locations that are not reporting this. And I think my suspicion is that this is related to the very high, the very low conditions of hygiene infrastructure and services in South Sudan. In many settlements, particularly villages in rural areas, but also in urban areas to an important extent, people are still relying on open defecation. And so, sometimes the enumerators, they cannot say yes or no, because, for instance, there might not be any latrines in a certain village. If we move to the next slide, this is the third indicator that we collect. Again, a very similar picture, whether there is lighting present surrounding toilets. And this is particularly challenging in South Sudan, where most of the country does not have access to electricity from the grid, and even local generators are quite rare. We can move to the next slide. Again, I want to show the disaggregation by type of settlement and by urban and rural areas. And really, the main picture here is that the only locations where a bit more has been done in terms of GBV risk mitigation surrounding WASH is in the very large camps. These are mostly located in urban and very urban areas. And because of the fact that these camps are managed by humanitarian partners, that they are very easily accessible by humanitarian partners, there is a bit more that has been done. But particularly in the host communities, only very few locations satisfy these very basic GBV risk mitigation indicators. Next. Right, so this is the overview that I wanted to give in terms of the current situation in South Sudan on risk mitigation as we capture it through DTM data, through DTM mobility tracking data. And to conclude, I wanted to discuss a bit about what data we may want to collect on GBV and where are we heading in South Sudan in particular in terms of data collection on GBV. And what we witness, I think, is an increasing demand for data on GBV prevalence, despite there being clear industry standards and recommendations that advise us not to collect this, that tell us very clearly that collecting this data is very often dangerous and doesn't necessarily benefit the communities that are affected. We also see a trend towards large household level multi-sector needs assessments that can evaluate and compare humanitarian needs across sectors and inform resource allocation. And I think we can suspect that the two are also linked. To the extent that there is a push for this consistent data at the household level, then GBV actors may not want to be left out in a sense and may want to include their own indicators of need. I'm not saying here, I'll be very clear about this, I'm not saying here that these multi-sector needs assessments are a bad thing. I think they're a very good thing. We are, as DTM, also participating in the South Sudan multi-sector needs assessment as a key partner in data collection. But I think for GBV indicators, we need to be particularly careful. And this is not only, and again, I put the only between inverted commas because the ethical and safety considerations are extremely important. But beyond these ethical and safety considerations, also from a data quality perspective, asking direct questions on GBV during broad household level assessments will really affect the quality of the data that we get. And not only this will happen, but it will happen more the more we are operating in a context where GBV is common and where there are severe gender inequalities at play. As GBV becomes more severe, more prevalent, women will feel less safe and less comfortable talking about it. And this will lead to more and more underreporting. And this is not only about data on prevalence, it's in general about any direct questions that are asked to women and girls in a context that's not protected enough for them to feel comfortable in sharing this information. Let's move to the next slide, and this is my conclusion. So in terms of way forward, from the discussions that we had internally within DTM, with our GBV and protection colleagues within IOM and with the cluster and area of responsibility in South Sudan, what we really think is that we really need to highlight the importance of reversing the burden of proof. We don't need to gather data on prevalence in emergencies. We can assume that GBV is happening. And this is something that's coming from the guidelines, from the IS guidelines. For IOM, it's also coming from our own internal GBV in crisis framework. So let's assume that GBV is happening. Let's assume that it is a problem and focus on the data gaps on the response side. There are a lot of gaps on in South Sudan on what response is available, what services are available for victims of GBV, starting from clinical management of rape by health services, but also GBV case management and counseling. And I think this ties to what Frey was saying about AAAQ, and including on GBV services. So this can apply both to GBV services and to risk mitigation in other services, whether it's WASH or it's food or NFI distribution. If individual level is needed, I think it's really important that we think carefully about whether it's a good idea to include a significant number of GBV indicators in large assessments like an MSNA versus doing targeted studies that are more likely to guarantee the conditions of safety, dignity, and confidentiality for the women that are involved. I think if we're just thinking about it from a pure data quality perspective, the quality of data that we will get by doing a small targeted survey where we're using only female enumerators, where we are carrying out the interviews in an environment that ensures confidentiality, where we know that there isn't the male head of household or a male neighbor overhearing the conversation. This will really improve the quality of the data. It will also mean that the respondents are participating in a safer and more dignified way. And with this, I can conclude. Happy to answer any questions. I hope this was interesting for the audience.
Thank you very much, Andrea. It was very interesting and very, I think, educative. I found it was very interesting. So thank you so much, both Frey and Andrea, a very good presentation of the data collection, what to collect and how, for example, DTM can be used. So let's move for our question. Now we are kind of pressing time, so I'll ask the question. So, yes, now we have a question from Tasha. May you please repeat possible reasons why IDPs in camp setting are less likely to live in settlement with areas avoided by women and girls, as are returnees in urban areas? Thank you. And also the question from Holly, identifying and mapping areas and situations where women and girls feel at risk of GBV. Men and boys can also be at risk of GBV. Is this also identified and mapped? These are two questions. Specifically.
Yeah, thank you. So to answer Tasha, I'll mention that we don't actually have research on this. What I was suggesting were just suppositions. What I was saying is that in IDP camps, it might be the case that in South Sudan, people from the same communities tend to live together in camp settings. And so they might feel more protected by the same community. While when they're living in host community settings, they are in a sense surrounded by a foreign community. And with the importance of family and clan structures in South Sudan, this might play a role in determining perceptions of security. But this is just a supposition. There may be other factors at play. It may be that there is some bias also in the key informants that in camps, they know that what they're saying is also affecting aid delivery, so there might be other factors at play. It would be actually very interesting, I think, to do some research on this to try and understand what are the factors that are driving this difference. For returnees in urban versus rural areas, I think in general, rural areas in South Sudan do have a problem with security, with the presence of armed groups that sometimes are quite loosely organized and can easily switch from armed groups to simple criminals. And I think this might be perhaps one of the reasons that's driving this difference. For the question on men and boys, there's a lot of stigma surrounding this in South Sudan. So we haven't included a question on this until now. I think in terms of areas avoided by men and boys, that if we were to add a question on that, it would more likely capture other forms of insecurity than sexual violence or GBV. But it's definitely an important area for analysis. I am not sure we would be able, because of the stigma, to collect valuable information on it through key informants. It may be something more for a qualitative type of research.
Great. Thank you so much, Andrea. Anyone has any question to Frey or Andrea? Okay, great. Thank you. So I see there's one more question for HLP. It's just because of the time, I think I'm going to skip, but we make sure that all the questions you listed in question and answer box are answered, and then we will send you the answers, the question and answers list after the webinar. So thank you again so much for all presenter, Andrea, Frey, Nora, Lama, and Peter. It was really, really helpful. We just want to do one more Mentimeter exercise to really get your opinions and recommendation before we go to the before we close the sessions. So please go to Mentimeter. Sorry, I have just a bit of problem with my. Sorry. Now back. Sorry, I had a bit of challenge. Now I think it's open. So could you please? Now it's open, the questions to Mentimeters. Do you have similar challenges in your country? So we received several presentations, and then all of them kind of showed particular challenges that women and girls face. For example, women have extra challenge on properties and GBV data collections and a compliant and the feedback mechanism. It would be great if you can also answer if you, in your setting, if you have similar challenges. See only 4 people coming. Maybe can someone type in the link to Mentimeter in chat box? Okay, so you can click the link in chat box, or you can type menti.com and then put the code 1800369. I only see 17 people, but I think more or less that we are hearing that women having extra challenge when seeking rent a property. That's our kind of common challenges that we see. Also, referral pathway that has to be adjusted because of the COVID-19. Also, needs assessment and monitoring, not always safe and ethical. That are some of the common, the top 3 common challenges I see in this Mentimeter. Let's go to the next. Now we have these challenges. So if you have these challenges, have you found any solutions to those challenges? For example, if your country women face extra challenges when seeking to rent a property, do you have any solutions like the example that Peter gave or Nora gave? If you think, no, there's no solution, it's 1, yes, we have very good solution, it's the 5. Great. So for data collections, I think there are, like more or less, there are some kind of solutions. And while I think HLP related to that challenges, I think much less solutions are found. And also challenge to link GBV or C survivors who seek support from compliance and feedback mechanism. That's also our challenges. It's great. Now it's changing. I think there's quite a lot of solutions are coming for the compliance and the feedback mechanism are not accessible for women. That's great. Again, we didn't have an opportunity to hear from you, the all participants, but please, again, feel free to share your examples and write in chat box and also contact us. Okay, for the time's sake, I'll move to the next questions. So we have just done the presentation on the HLPs and this event, but we want to know if you want to know more about any specific topic. For example, GBV integration into HLP, we had lots of questions. Unfortunately, we couldn't answer all the questions, but it really shows a lot of interest. So please vote anything that you are interested in knowing more. And we'll ask another questions, how we can kind of satisfy your learning needs and the challenges. Great, yes, lots of them. GBV related data collections, how to identify GBV risks, roles of CCCM clusters in GBV risk mitigation, GBV integration into compliance and feedback mechanism, GBV integration into other AORs too, GBV integration into general protection, I think more, HLP. So it's actually how to identify GBV risks across sectors are quite a top needs of learning, very interesting. And then they're followed by the GBV related to data collections, and then again, compliance and feedback mechanism. Excellent. So I'll go to the next one. Now it's the ranking. So what can we do? For example, our global protection cluster GBV AOR, global GBV AOR, GBV guidelines reference group. What technical support will be helpful to address your challenge and also address your learning needs? We see quite a lot of, I think, requests for the many people, actually majority of people are interested in strongly to learn about how to identify GBV risks across sectors and also the compliance and feedback mechanism. What could be helpful? Is that online training or a similar webinar or just getting case studies from other countries or, bilateral technical support from help desk or someone else, or just facilitating some kind of peer learning among the practitioners? What could be most helpful? I think you can pick top 3. And then please take your time to vote because we want to follow up these results after this webinar. So webinar similar to this one, peer learning, yes, and online training. Case studies, yes. Online training coming top. I think there is competition between the peer learning and webinar. Now case study got the 2nd place. Great. So generally the online training is the most, I think, interested options, most popular options, but case studies, webinar similar. I think there are not so much difference between second. So online training is something that participants here are very much interested in on the topics that we voted just previously. And all the other, I think, things are kind of similar. Great. Finally, we really wanted to hear more. Sorry that we didn't have enough time, but please share with us your recommendation for the GBV AOR, the Global Protection Cluster and other AORs and CCCM to better integrate GBV risk mitigation in protection work. The presenter gave several concrete recommendations. We took note. but it would be really good if we can hear also from you what we could do better to really challenge, to support to address your challenges, and making sure that GBV risks are mitigated across the protection work. What is the RAS? Separate training on sub-subject, okay. Actually, we have a lot of topics, and then we didn't have enough time. That's something we can learn. High-level political will and leadership, direct funding to women's rights organizations, organizations of persons with disabilities, great. Better coordination, more support in operationalizing guidelines across sectors, case studies, lessons learned. Enhance coordinations, great. Have more interactive session like this so that field experience can be shared, great. Includes coordination with IC, MH, mental health and psychosocial support reference group, yes. It'd be great to provide technical support at country level for this to be effective. Excellent. Increase the funding and a more in-country training opportunity. Global protection cluster and its AORs. Be great to know more about it. And strategic partnership and increased coordination. Ensure that participation in the most vulnerable groups and supporting women-led organizations. We hear a lot women-led organization. Also increase the information sharing between different operations, regions, and sectors. Excellent. I'll keep this open until we close the sessions. I will stop showing this, but we will have this record of these Mentimeters, and then we will make sure we will review your recommendations. So I will keep it open. So please keep writing your recommendations. Now, because of the time, we need to close, and I'm so sorry that we didn't have enough time to share your experiences and then answer the questions. Before you close, please also take time to put this to fill the evaluation form. We will send the evaluation form later, but please make sure that you write the evaluation so that we can improve in the future. So now while you're writing the recommendations in Mentimeters, and also if you are done, please write evaluation. I will now introduce, I will hand over to William Gemelli, Global Protection Cluster Coordinator, to close these sessions. William, over to you.
Thanks very much, Masumi. Can you hear me well?
Yes, I can.
Very good. I'm trying to put on my video, but that's not working. You're not allowing me to, but that's fine. First, thank you so much, colleagues, for this session. Without the need to really compare between different sessions of the Global Protection Forum, I can comfortably say that this has been one of the best sessions that bringing together the whole spectrum of protection work. 3 ways clearly stood out. First, the discussion showed in practice how addressing gender-based violence is everyone's responsibility. Many speakers repeated that. And everyone means everyone, beyond and including protection actors. And in a time of peace and development nexus, we have to take all the knowledge that you've put today on the table and take it beyond also the humanitarian spectrum to the peace and development action in cases of conflict and disasters. The second thing is that we heard clear examples how a good gender-based violence response has to look into the wider protection response. Responding to GBV, of course, requires important level of specialization and expertise. It also requires, as we heard from several countries, from GBV actors to look into the wider protection environment and help others understand the linkages, repercussions, and wider impact. In many ways, GBV actors have to be the whip and the catalyst for other actors to do their job. Third, we heard clearly how gender-based violence is a result of a multi-layered mess and crimes of power huggers. GBV is a result of wider violence, as we heard from several operations, unjust systems of laws, traditions that reinforce the inequalities, poverty and lack of livelihoods, bad humanitarian development and peace programming also. But that is no news to the audience here today. But what it means is that investing in mitigating gender-based violence, the focus of today, investing in mitigating gender-based violence is probably the smartest protection investment we can all make. Because as GBV is a result of all these layers of problems, if we get mitigation right, then we are directly also addressing wider violence, unjust systems and laws, traditions that reinforce inequalities, poverty and lack of livelihoods, and bad humanitarian development and peace programs. So where does that leave us after today's session? First, a congratulation is due to the GBV community for being, dare I say, ahead of many other specialized areas in protection, for working with and responsibilizing others. Thanks to everyone on this call, to all the local actors, civil society, NGOs, and member states that focus on this area of work in a transversal way, in a way that actually tries effortlessly to pull all the actors around this important topic. Second, we heard very good practices, tips, and recommendations regarding HLP, complaints, and feedback mechanisms. We heard from colleagues on data collection and monitoring. As you know, the protection areas of responsibilities and specialization are rolling out this year a set of minimum package, otherwise we refer to as basics, to make sure is in place in all our operations. So my second point is that your recommendations today and all what you're putting in the Mentimeter now, I commit to make sure it finds its way to this minimum package that will be formally rolling out. Hopefully this way we'll have many more examples in the next setups and discussions around this topic of good practices and stronger linkages with where other actors are taking their GBV responsibility successfully and seriously. So as Jennifer said at the opening speech, this is a continuation for our engagement to mitigate GBV risks in protection work. And we're keen to continue this conversation. Masumi, you have brilliantly facilitated this vibrant session. With such performance, we might have to steal you to other parts of protection work. Or, as we have seen today, make sure you remain in the GBV portfolio as being one of the most impactful portfolios on wider protection issues and other areas of specialization. So with this, I thank you all for this great session and looking forward for further conversations in this Global Protection Forum. Thank you, and over to you, Masumi.
Thank you very much, William, for our very encouraging words that, again, we will follow up all these recommendations. So please also take your time to take evaluations, and please feel free to share your thoughts, your experiences. And again, thank you very much again for all presenters, and also Katie, William, and Jennifer for presenting your views. Thank you very much for everyone. And thank you so much for all organizers to make it happen. Thank you.